So we're here to continue on with the series that I'm calling Don't Believe the Hype. Now, one of the things that I want to take a look at here is the discussion around varying osteopathic techniques or varying types of osteopathic treatment methodology, and the fact that they can be claimed to be different, or that people make the attempt to claim that they're different. Now, I've put forth a concept. Now, I did a webinar with Osteopathic of Ireland, which is now, I believe, Advanced CPD, and that video I will have already shared in multiple places, but the basic concept that I've come to is what I call a PTB model of osteopathic treatment or osteopathic approach. So the P being patient activity, the patient is either active or passive, the T being the tissue or tissues targeted, and the B being the barrier. So in all osteopathic treatment methodologies, you have patient activity, the tissue or the tissues targeted, and the barrier concept. Now, I think that based on analyzing what's available to us, that does a fairly sufficient job in being the overview, being the directive concept for how to create a treatment, especially when considering that the patient is the end user. Now, a way that has been mobilized to teach people how to create treatment is varying treatment systems or varying technique systems. What I want to do is go through the foundations of osteopathic medicine such that I just take the clips of each of these systems that are included in the foundations of osteopathic medicine. Now, there are other treatment techniques or treatment systems that exist that are not included here. However, the ones that are here, I think it's reasonable to suggest that we can agree they're fairly standard. You're going to find them in many places. Foundations of Osteopathic Medicine is a fairly standard textbook, if I'm not mistaken, in many parts of the world that are not America, right? So there will be schools in Canada that use it, schools in New Zealand, schools in Australia, very likely schools in the UK. I am not 100% aware of that, but I would call this a fairly standard textbook, such that we could look at what's said here to create some form of unified concept, right? Or at least the general headings that I'm going to show should give us the opportunity to have some insight into how we've attempted to teach people how to treat, just very, very 30,000 foot view kind of deal, and then why I take the position that these systems really are not all that different. They have the same core things, and if we focused on those same core things, we may be able to more functionally educate people such that when they're encountering a novel situation, they can be guided by a concept and they can come up with a novel solution instead of trying to remember procedural differences. You know, is this the thing that's best for counter strain? Is this the thing that's best for osteopathy in the cranial field? What have you. But the basic concept primarily being that I'm going to show you, again, a very 30,000 foot view approach to how we've been putting forth educational material in the osteopathic profession, and then hopefully you'll see why I suggest a possible alternative. Am I saying my alternative is the perfect one? No. But I am saying that it's one that I can utilize, that I can wield to provide functional outcomes for people trying to learn things. You are completely free to come up with your own way to do the same thing. You know, and just the reality of how human psychology works, no matter what we come up with, we as individuals believe we're correct. So even if I'm breaking a rule, if I'm specifically breaking a law, and I know I'm doing it, I think I'm right for doing it. Otherwise, I wouldn't do it. I'd avoid the behavior. So that said, obviously I think I'm onto something, but the degree of certainty that I have is not perfect, right? I think that all systems have patient activity, the tissue or tissues targeted, and the barrier concept. And if you stay there and you teach how to subdivide off of those things, you then have an opportunity to teach somebody how to create a treatment that is aimed at the individual patient that's in front of them. Okay, so we look at foundations of osteopathic medicine into the sections where they're describing osteopathic methodologies. And the first one that we get is HVLA. Okay, so try to zoom in on that just a little bit so it may be a little bit more legible on the television. But the HVLA, so what they have here as your bullet points, the high velocity, low amplitude thrust approach is characterized by positioning to engage restrictive barrier, followed by a corrective maneuver to move through the barrier. Okay, so position for correction initially, take people to bind, take people to the direct barrier. Accurate diagnosis is the key to performance of HVLA, so diagnosis is important. The idea is that if you have not diagnosed, you would not know where to take the person as far as barrier is concerned, so you take them to the barrier and in all planes, and then you essentially add some extra force in the direction or directions that are required for correction, and you do it fairly fast, right? The thing that's central to this is diagnosis, right? So you have a diagnosis, you know what you need to do, you have your barrier choice, right? So the barrier choice is direct barrier. The tissues targeted, or the tissue or tissues targeted here, you could say, depending on how you look at this, could be neurological tissues, it's very unlikely to be soft tissues unless you're saying the neurology drives the muscle, and then articular tissues or joints or bony tissues, hard tissues, right? So you're really looking at a neurological and essentially an articular approach or a hard tissue approach. So HVLA has patient activity, so the patient's passive, that has your barrier choice, direct barrier, and it implies tissues targeted, okay? We look at the next one, muscle energy approach. So muscle energy is a plan of diagnosis and treatment which relies on active patient effort through muscular contraction. So patient active, right? So the patient activity is patient is active. This approach requires active use of the patient's muscles on request from a precisely controlled position in a specific direction against a distinctly executed counterforce, which most people automatically assume is going to be the practitioner or the operator or the physician or the osteopathic manual practitioner, however you want to term it. But that could just be a highly immovable object. You can have somebody press against a wall, press against a table, press against the floor. It doesn't have to be the practitioner. And then it talks about post-isometric relaxation. So what we get from this very quickly, patient active, the tissue or tissues targeted, essentially you're looking at a neurological response here. So you have a neurological tissue thing going on, and then the barrier, although not explicitly stated here, muscle energy approaches are very generally used directly. They can be used with the indirect barrier, however, in most cases people will go direct, so you have your barrier choice again. Myofascial release. This approach emphasizes appreciation and recruitment of the innate and inherent motion of the myofascial structure, so motion is central to everything. In osteopathy, if you're not talking about motion, it doesn't seem like you're talking about anything. If you're not talking about the motion of the practitioner or the motion of the patient's structures, we're probably not having a discussion. It doesn't mean that people don't try to, that's probably not what's going on. Patterns of motion and ease are identified across proximal and distal structures, diaphragms, compartments, viscera, and organ systems. Techniques of this type are myofascial release, integrated neuromuscular skeletal release, fascial ligamentous release, and bioelectric fascial activation and release. Respiratory assistance, fulcrums, body position, neuroreflexive activities, oscillation, passive progressive motion, muscular contractions. So in myofascial release, there are approaches that will be patient passive and patient active. So, muscular contractions is patient active, passive progressive motion. So you're moving the patient. Neuroreflexive activities, patient active, body position, respiratory assistance, patient active, oscillation is patient passive. So we have options for patient active or passive. In myofascial release, we have options for either barrier, direct or indirect, and the patient, again, active or passive, and then the tissues targeted, realistically speaking, based on the name, muscles and fascia, so soft tissues. However, there may be people talking about essentially neurological phenomena. So you have, again, the patient activity, the tissue or tissues targeted, and you have the barrier concept. So there's a fair amount of choice within those three concepts, those three overarching concepts, but all of that is contained within MFR. Osteopathy in the cranial field delineates an anatomically based understanding of range and vector of motion, physiological dynamics of cranial bones and intracranial structures. Primary respiratory mechanism is a functional unit based on the accommodative actions of cranial articular surfaces. Traditional model of OCF includes 5 phenomena: inherent rhythmic motion of the brain and spinal cord, fluctuation of cerebrospinal fluid, mobility of intracranial and interspinal membranes, articular mobility of cranial bones, and involuntary mobility of sacrum between ilia. So this particular kind of bullet point really just harps on motion, right? So motion of varying structures. I have personal critiques backed up by a fair amount of evidence that I've provided before with respect to the cranial mechanism and the way that it's approached. That doesn't matter here. When you're looking at osteopathy in the cranial field, no matter what angle you look at it from, you're looking for motion. If you're going to be dealing with motion, although not specifically said here, you are going to be looking, when you go to treat, at your patient activity, the tissue or tissues targeted, and the barrier concept. Within osteopathy in the cranial field, when I did the analysis of technique terms that led me to the PTB model, osteopathy in the cranial field includes patient active and patient passive. It includes all tissues, depending on where in the cranium that you're working, whether you're working in the facial region or kind of top of the head. It includes all barriers, right? So osteopathy in the cranial field essentially is, as it says, it's osteopathy. So patient activity, tissue or tissues targeted, barrier concept. It just happens to be that you're doing it in the head. So it's actually a reasonable name when you say osteopathy in the cranial field, because the same stuff, the same concepts that would guide you anywhere else in the body guides you when you get up essentially above the neck. That being said, the way that it's practiced may not always work the way we hope it to work, but again, all of those are available when you look at further detail, further written detail about osteopathy in the cranial field. All forms of patient activity are present in it as a system sense. All tissues are included and all barriers are included. So osteopathy in the cranial field fits this PTB model. Strain counterstrain. Astute clinical observation by Jones, followed by progressive exploration of a line of thought, represents the development of this approach. Treatment of somatic dysfunction can be enhanced by placing the patient's body in a position of maximum comfort. Effective use of this approach requires the exploration of anterior and posterior body areas for appropriate diagnoses. And then it just talks about tender points and correlations, right? We're not going to be too concerned with those correlations or those tender points, simply on account of the fact that sometimes they're tenuous, they're observational, they're not as empirical as we'd like them to be. That's okay, but here we're talking about, again, the bullet points, not a full explanation, but when you look at strain counterstrain, usually you're seeing somebody with what I call the ET phone home, you know, like the outstretched finger. You find the tender point, you push on it, and then you create movements which create increased comfort at that tender point, decreased pain, however you'd like to term it. But essentially it's an indirect approach, so it's a patient passive approach for the most part. The patient may actively move into a position of comfort, right? So it could be patient active or patient passive. The tissue or tissues targeted, you can claim it's whatever tissue you're palpating, but generally speaking, the pain, the nociception that you're attempting to interface with is a neurological phenomenon. So the tissue or tissues targeted, in this case, probably neurological. You can make arguments for other things, that's fine, but then the barrier is indirect, right? So the PTB model fits strain counterstrain, right? You're just happening to be very focused. So strain counterstrain, as it's practiced today, is essentially indirect in a very small spot, where you may use very large motions to decrease nociception in that area. But again, it fits this PTB model. Soft tissue or articulatory approach. Soft tissue techniques are directly applied to the muscular and fascial structures of the body and affect the associated neural and vascular elements. Soft tissue preparation facilitates improvement of articular motion. Basic tenet of manipulative intervention has been consistent in the history of osteopathic medicine. So basically, the philosophical approach here is treat the soft tissues to make the joints move better. But you are going to, when treating soft tissue, use a patient active or a patient passive approach, right? Generally speaking, when you're working on soft tissues, it's a patient passive approach. You are going to be targeting soft tissues. However, your aim in targeting soft tissues may be to do something to hard tissues, maybe to do something to a neurological tissue, or to essentially a fluid tissue or a vascular tissue, however you'd like to term that. But again, and then you can go direct or indirect. So again, all of these things fall here. The soft tissue or articulatory approach or the soft tissue approach, really you could just call it MFR, right? They're somewhat interchangeable here. You don't have to do that, but you can. My whole aim here, again, as I'm going through all of this, is to highlight that all of these things fit this PTB model, therefore they don't need to be broken apart. You can break them apart. Some people will not feel comfortable with not breaking them apart and keeping what they believe are firm boundaries, but there are no real firm boundaries aside from minor procedural steps, which I talked about in the indirect video that I've done, right? The lymphatics approach, lymphatic system plays a major role in numerous homeostatic mechanisms of the body. Lymphatic system is particularly vulnerable to fascial dysfunction in the region of the superior thoracic outlet, or inlet, depends on how you look at it, whether you're thinking about veins or arteries. Initial draining of the lymphatic system must always be done through terminal areas. How do you treat the lymphatic system? You remove restrictions in areas that would be considered essentially lymphatic, points of lymphatic stasis, points of lymphatic, kind of lymphatic choke points. If you're talking about the lymphatic system, you're going to have to use soft tissue and hard tissue approaches. Gordon, I've seen DVDs of Gordon Zink treating, and he is known to have done quite a bit for the lymphatics. And he was a wax, smack, and crack practitioner. He cracked a lot of stuff, and then there was an impact on the lymphatics based on what he reported, patients reported to him. Right, so the level of evidence that that represents, you can decide for yourself, that's fine. But the reality is that when you see somebody who is talking about treating lymphatics, they're cracking, they're doing HVLA essentially. There are other people who will do soft tissue approaches, but how do you treat it? Patient active or patient passive, tissue or tissues targeted. In this case, you're thinking about the vascular tissue or the fluid-based tissues, but you may have to do a hard tissue or a soft tissue approach to do it. And then the barrier in which you do that, you may go direct or indirect. Again, this, if you see swelling somewhere, check the things that are moving around it, right? The things that are moving as they should, you need not pay attention to. The things that are not moving, you pay attention to and you do something about. So now we get into some others. Balanced ligamentous tension, so BLT, and LAS, ligamentous articular strain. In this section, emphasis is placed on the role of ligaments in maintaining articular dysfunction. Cardinal principles of this approach are 3: disengagement of the dysfunctional area with compression or decompression, exaggeration of the dysfunctional pattern, returning to the original position of injury, and balanced tension of ligaments maintained until release. Retracing the path of injury via ligamentous tension and strain is done anatomically and facilitated by respiratory cooperation of the patient. So, patient activity, respiratory cooperation, patient's active, the tissue or tissues targeted, ligaments. Okay, you're thinking about ligaments. It doesn't mean that's necessarily what it looks like, that the only thing that's moving is ligaments. You're very likely using a limb as a lever, so you're using a bone to move in relation to another bone to do something to the ligaments. It's your point of attention, but it's not necessarily that you're grabbing a ligament and wiggling it and moving it. That's not what's happening. You're grabbing something and moving a bone in relation to another bone. But the idea is that, again, patient active with respiration, you can do BLT, LAS, or any form of indirect approach, patient active or patient passive. You don't have to move in the direct area of injury. So say the neck is the problem, I can move the arm, right? So I can turn the head, move the arm, I can keep the neck still, keep the neck calm, but the patient can be active. It's one of the things that respiratory assistance often accomplishes, is that you get large motion of the thorax, of the abdomen, in relation to a still part somewhere else. So it's just a way to create a patient active approach without directly moving the area. But BLT fits this PTB model. Facilitated positional release. In this section, emphasis is placed on decreasing muscular hypertonicity involved in the maintenance of articular dysfunction. The dysfunctional region is initially placed in a relatively neutral position. Activating force, compression, traction, or torsion is applied to effect immediate release of tissue tension, articular restriction, or both. Subsequent positioning into resistance seeks to affect larger regional muscle groups or smaller intrinsic deep muscles involved in joint mobility. So essentially, patient is generally passive in facilitated positional release. It doesn't mean that they have to be, but generally they're passive. You're talking about the tissues or tissues targeted, so soft tissues and neurological, essentially through a neurological mechanism. And then by extension, the hard tissues, the articular surfaces will change. You're looking at indirect here, right? So it's generally an indirect approach. Indirect approaches, essentially when you're going to do them, the way that I suggest you think about it is make the soft tissue soft. But again, facilitated positional release fits this PTB model. Progressive inhibition of neuromuscular structures. In this section, emphasis is placed on decreasing tissue tonicity, so tissue tone. So we're looking at soft tissues here. Clinical symptoms are assumed to be directly related to increased dysfunctional tone. Steady pressure, constant mild or moderate force is applied to regions of dysfunction. The relationship between musculoskeletal structures and underlying visceral organs is also considered. So it's just stuff we're thinking about. Whether or not it's happening is maybe not worth considering. But if you'd like to think about something at length and have no proof of it, go ahead and think that, you know, I'm holding on to the right shoulder, therefore I'm directly affecting the gallbladder through embryology. If you'd like to think for a long time, be my guest. I wouldn't suggest that you're having the impact that you think you're having, but it's nice to think for a long time if you need to fall asleep, right? But what you have here is you have something that's directed. So the patient is passive, you're directing it at soft tissues, you're probably really thinking about a neurological mechanism, so those are the tissues targeted, by decreasing tone, and it doesn't really specify a barrier, so you could do this direct or indirect, but again, fits the PTB model. Functional technique, emphasis placed on input, physician palpated and evaluated at the segmental level, the sense of ease or compliance and bind, increasing palpable resistance used to interpret the motion input, opposite asymmetries. This is a bit of kind of word soup. They talk about the component of visceral influences recognized through the concepts of lack of accord and linkage. So you are making a rational jump again with the involvement of visceral structures. So if you'd like to put yourself to sleep by thinking about stuff for a long time, go ahead think about the visceral stuff if you like. But again, your level of evidence from the outside of the body working on motion, that's what you're working on is motion, you're very unlikely to be able to accurately identify what's happening to viscera at the level that would be required to make the claim. That's fine, but what you're looking at in functional technique, the patient is both active and passive, so the patient may make the initial movement into the position of general ease, the practitioner may then create some passive motion. The physician can ask the patient to use respiratory assistance, so the patient's breathing anyways. The physician or the practitioner may accidentally or purposely follow that change in breath to create more ease. So you have the patient activity. Patient can be both active and passive. Tissues targeted, essentially you're looking at soft tissues through a new neurological mechanism or a proposed neurological mechanism, and you are working indirect, you're making the soft tissue soft. Again, fits the PTB model. Visceral manipulation. In this section, emphasis is placed on direct palpation, evaluation, diagnosis, and treatment of viscera, aka you're primarily touching the body surface in the region of the abdomen or the region of the thorax, and then sometimes the region of the neck, and depending on the countries that you live in and the laws that are governed, you may do some other things that you won't find many practitioners in the place that I am, which is in Ontario, doing. That's fine. But what you're looking at is you're looking at motion in relation to your ability to touch those surfaces. There's claims that you're accurately touching organs. I'm not accepting of those claims for the most part. I would suggest that if you can clearly palpate an organ, you should probably call 911. It's likely a problem. But what you have here with visceral, so you're looking at motion, so the patient is generally passive, however respiration is considered a central part of the visceral system. So the patient is passive as far as gross motion, however they are still breathing, so they're still active. You have the tissue or tissues targeted. Realistically, you believe that you are targeting organs, but you're treating organs essentially as soft tissues, and there will be articular motion, so sometimes there's long lever approaches. And then you have the barrier, and there are interesting terms of art within the visceral model, but essentially you're going, the way that they use indirect and direct ends up being somewhat counterintuitive. However, you can pull back from that and just say direct and indirect as it's commonly used. So direct being into bind, indirect being away from bind or into ease. Again, the visceral system, regardless of what I have put forth with evidence to make claims about its efficacy, at its root, it is still following this PTB concept. Still technique in this position, emphasis is placed on the introduction of a force vector, resulting in a smooth arc carried towards a position of tissue compliance. Position is altered while maintaining this force, carrying it toward, through the position of a restricted position. I messed up there. Toward and through the position of restricted position in motion. That is an oddly written sentence. Historically, this is described as redevelopment of manipulative method, developed and used by Andrew Taylor Still. So essentially, it's go indirect followed by going direct, right? The way that I will talk about making choices in treatment with respect to which barrier you choose, if there is no pain upon going direct or going into bind, you are free to go direct because you're not causing any pain to the patient as the end user. If there is pain, go indirect, right? So there's the choice. The choice is pain, go indirect. No pain, go direct. If you want to remove the choice, essentially what you're doing is still technique. You remove the choice by no matter what you find, you go indirect followed by direct, right? So you just remove your barrier choice. But in performing this system, in performing going indirect followed by direct, what you have available to you is varying levels of patient activity, and you have all tissues targeted, or essentially the opportunity to target all tissues. You can believe that you're targeting one tissue more than another. That's of little matter, essentially on account of the fact that it's available to you. The salient feature of still technique is removing barrier choice by choosing beforehand that you're going to go indirect followed by direct no matter what you do, and that's still technique, right? But again, it still fits this PTB model. Chapman's approach, the section emphasis placed on identification of gangliform contractions believed to be fascial congestions, believed, resulting from lymph stasis secondary to visceral dysfunction. Again, lots of thinking. You found something lumpy, right? You find something lumpy. These contractions are generally deep to the skin and subcutaneous tissue, most often lying on the deep fascia or periosteum. Generally described as neurolymphatic points, vibratory stimulation is utilized for reduction, elimination of the point. So basically you find a lump that you will somehow, through some description, classify as one of these neurolymphatic points. You touch it and you shake it. So patient is passive. Tissues that you're targeting you believe to be neurolymphatic, whether they are or not mine to choose. Mine to doubt, not mine to choose. And then you shake them, right? The shaking, there is no barrier choice, right? So it's possible to argue that this doesn't necessarily fully fit the PTB model. However, the lack of choice in barrier is because the methodology is you take this thing and you shake it, right? That's the prescribed methodology. Whether it works or not, again, up for discussion, that's fine. So and finally we get to Fulford percussion. Now Fulford percussion, essentially we take from these bullet points. In the section, emphasis is placed on synchronization of palpatory diagnostic interpretation with the application of an external percussion device. This device, the percussion vibrator, amplifies what is normally done through the hands alone and thus can increase the amount of energy delivered to the tissues. The energy state in the dysfunction field must be matched properly to release it. Intrinsic to this approach is incorporation of thought derived from Andrew Taylor Still's expression of mind-matter motion. That's really just kind of a final add-on sentence. With Fulford percussion, essentially what you have is a soft tissue approach, right? So the patient can actively move into a certain position, right? You assess soft tissue bind, right? So you move soft tissues, you find in one plane or in multiple planes the bind or ease with respect to the soft tissue that you're interested in. You go to the nearest bony prominence, you apply the percussion hammer, and you basically hit the bone with it. So you shake the bone in relation to a relatively still soft tissue that's on ease or on bind. Whatever you choose for whatever reason you choose it. The way to identify if the speed of the hammer is properly, and this is where they talk about the energy field must be matched properly. The reality is that when you're using the hammer and hitting the bone, it will start to sound like it's getting bogged down, right? So a motor that sounds like it's singing smoothly, something that sounds like it's getting bogged down, right? Just some auditory indication of what it might sound like. It just sounds wrong, right? Then the claim is made that it's not matching the energy field. So whether you'd like to believe in the energy field or just believe that you're going on an auditory cue that the thing sounds like it's getting bogged down, up to you. I would personally go with, if it sounds like it's getting bogged down, wrong speed. Okay, but what you have is generally a patient passive approach. The patient can help you get into your position of ease or bind on that soft tissue. Your approach, the tissue or tissue is targeted, you're targeting soft tissue by holding the soft tissue still and moving the bone in relation to it, so it's really a soft tissue approach. Then the barrier, you can choose direct or indirect for whatever reasons you choose it. So this again fits the PTB model. So having gone through what's present in the foundations of osteopathic medicine, as far as systems and treatment approaches are concerned, what we are able to identify is that essentially all of these systems, aside from Chapman's approach, neatly fit the PTB model that I'm putting forth and that I'm trying to talk about. So my general contention is that this PTB approach allows essentially for us to simplify or maybe streamline our teaching approach, right? If we simplify or streamline our teaching approach, we may end up creating the ability to solve novel problems without being bogged down in procedural memory or procedural steps. So if you're trying to teach somebody the ability to problem solve and you're teaching them procedural steps, so I would argue that almost all of these treatment systems really are just long lists of procedural steps that can be confusing, especially when you try to remember them. If you're trying to teach problem solving by teaching procedural steps, if they're not procedural problem solving steps, you have a challenge. What I would say is that the PTB approach has at least the opportunity to provide a problem solving approach, right? A problem solving procedure. The questions you're asking in the procedure of the PTB model is, will the patient be active or passive? Am I aiming at hard tissue, soft tissue, neurological tissue, or fluid tissue, or vasculature, depending on how you want to term it? And then, will I go direct? Will I go indirect? And if I want to use both, that's fine, right? So you have a procedural or a set of problem solving steps that need to be filled in with detail and explanation and essentially demonstration. You need to show people what these things look like. But if every time you're explicitly showing people what they look like, what indirect looks like versus direct looks like, what doing something that would be considered neurological versus hard tissue versus soft tissue versus vascular tissue, what those look like versus, you know, is the patient active or passive? If everything you're doing is like that, then what you're doing is priming for the ability to solve those problems and use those approaches, as opposed to saying, no, this is an HVLA thing. No, this is an FPR thing. No, this is an MFR thing. No, this is a muscle energy thing. I would suggest that those procedural steps are large in number, large in steps, they're high cognitive load, and they may not necessarily have the intended outcome. My aim with this PTB approach, or to describe it and try to take you through how all of these again, aside from the Chapman's reflex approach, neatly fit the PTB model, is to suggest to you that we don't need to use all of these segregated steps. We can kind of take this Bruce Lee approach, right? From a once united whole, there are many fractured pieces in the martial arts. Now with mixed martial arts, that's coming back together because you're putting them in the crucible of a fight to prove whether or not they work. That's kind of a side point to help illustrate my general claim that osteopathy or osteopathic manual medicine or osteopathic manual manipulation, however you want to talk about it, was a united whole at one point and then got fractured into separate pieces. We have the opportunity in varying ways, not the way that I'm suggesting a way to unite the concept so that we can teach people how to be novel problem solvers, demonstrate how to use these novel problem solving steps, therefore they're able to do a basic competency level treatment, and then as they go and they continue to use this PTB approach, they get better and better, they get more experience, they get more knowledge, and they are able to improve and solve novel problems, because clinical practice is highlighted by novel problems. Somebody that you don't know comes in with something that you don't know about, and you've got to figure it out, figure out what it is, and then figure out what to do about it. if we're teaching people how to muscle energy everything, if we're teaching people how to osteopathic in the cranial field everything, if we're teaching people how to fold for percussion everything, regardless of what step you want to talk about or what system you want to talk about, we're segregating it, we're creating higher cognitive load. I'm hoping that I'm giving you information that suggests that a different approach that unites all of these is lower cognitive load and will improve problem-solving capacity in novel situations, and therefore at least has a chance at creating a better educational environment for people learning osteopathic manual therapy. So that's the to kind of wrap it up in a way that I normally do. I would say in this case the hype is all these different systems, that they're really different. They're really not different. They have the same underlying structures, they just have different window dressing and different procedural steps. So the hype is that they're different. Don't believe that hype. Identify the things that are the same. You don't need to do it the way that I do. This PTB approach, patient activity, the tissue or tissues targeted, and the barrier concept, this is the approach that I've come to by actively analyzing materials that are available. You can come to a different approach, but ideally you want to minimize cognitive load. Don't make people think in too complicated a way or else they may not be able to act. And you want to essentially provide an opportunity to avoid thinking about procedural steps, individual procedural steps, focus more on the patient, but in doing that, by having a novel problem solver, okay? So don't believe the hype, stop spreading the hype.